Hello, hello, hello. Good morning, students. Good morning. Am I visible to all? Am I audible to all? All of you quickly settle down. Yes. Good morning, all of you. Good morning. Is the audio video all clear? Am I visible to all? Am I audible to all? Okay. Yes. Quickly settle down. And can anybody tell me if the Yes, yes, definitely better. Definitely, yes. That is a good decision. Of course, all questions will be coming from there only. Just 1 second. Please. Okay, so I think all of you are joining in. Quickly settle down. I'll just give you the pre-cap and a recap so that all of you understand what is the agenda for the day. Yes, already all of you ready. So just a quick pre-cap and a recap. What all we have discussed yesterday. What all we have discussed yesterday. Very, very important topics. And definitely from that, questions are going to come. Questions are going to come. Okay, so yesterday we have discussed about the topics of very important topics of MALP. We discussed about the active management third stage labor, based on which questions are surely coming. Then we went on to discuss normal labor mechanism. Questions may or may not come. Very, very important. Everything we have discussed. Yes or no? Thumbs up. Breach, 2 to 3 questions are coming many times. Okay, breach in detail. When to do vaginal delivery, when to do C-section. Thumbs up if you remember, including ECV, everything. Breach, transverse lie, oblique lie, brow and face, all the types of malpresentation we have discussed. Today, very important, we will be starting with malposition in the first 30 minutes. Very interesting, please pay careful attention. And then yesterday we discussed all about the PPH. Malposition karenge, forceps and vacuum karenge, and most important topic for the day, pre-eclampsia, time permitting, will also be doing a minor topic of VBAC or starting with anemia and heart disease. Okay, is it ready? Thumbs up if all of you remember this and all this if you recollect. But Yesterday, we had told you all the drugs about PPH. Yes, I repeat, tranexamic acid when given, oxytocin 20 to 40 units diluted, we always give. Never give IV bolus. Okay, oxytocin, remember, never IV bolus. Please make a note. Because if you give IV bolus का मतलब है कि undiluted directly, I open the vial and I directly push, sudden hypotension and the patient BP can crash. Okay, so we never give IV bolus, we always give in a form of IV infusion. Infusion matlab you have to dilute it. Okay, PGF2 alpha is always intramuscular, misoprostol, all that we have discussed. Yes or no, thumbs up if all of you remember this. And the last thing what I told you about this, the Bakri balloon tamponade and the B Lynch suture. Now, surely this question is coming. Anybody, what is carbetocin? कभी सुना है, कभी what is carbetocin? नाम से कुछ आइडिया आ रहा है? Carbetocin. Surely 5-star recent advances for the upcoming difficult exam. Next level MCQ. Yes, anybody, chalo, out of the 100 students, anybody. Okay, so carbetocin, yes, very good, Vijaya, same like oxytocin, but what is the speciality? So remember, my dear students, oxytocin ka problem kya hai? कि oxytocin, by the way, remember, is considered the first drug of choice. Okay, oxytocin is the first drug of choice, लेकिन oxytocin requires fridge, रेफ्रिजरेशन, उसको ठंडा रखना पड़ता है, कोल्ड चेन हैज टू बी मेंटेन. सो ऑक्सीटोसिन का प्रॉब्लम क्या है कि इफ ऑक्सीटोसिन का proper refrigeration is not done and the temperature is not maintained, then the oxytocin will lose its potency. कुछ काम का नहीं है. तो carbetocin is a new drug. Yes, it is a oxytocin analog. It has an action like oxytocin. Okay, it is a oxytocin like a drug, but very good, Vijaya, that the advantage is it is stable at room temperature. Please make a note. So heat stable or stable at room temperature, carbetocin. Is this understood to all of you? It's oxytocin agonist, we can say, or like a oxytocin analog, but it is stable at room temperature. Clap if you have learned something new. And two more points. It is for both prevention and treatment. 100 microgram dose, all that will not be asked to you. But just one important point, revision. I told you oxytocin का क्या दो uses है? Sir, oxytocin, yes or no? I can give for induction of labor also, and I can give for PPH also. Do you agree with me? Yes, but carbetocin, my dear student, carbetocin, the action is like methergin. It will, or like high dose of oxytocin, it will cause both upper lower segment to contract together. So carbetocin is only for PPH and never for induction of labor. Is this understood to all of you? So in the whole obstetrics, carbetocin ka only one use, only for PPH. Is this understood to all of you? Thumbs up. खाली एक ही चीज याद रखना है आपको, खाली इतना ही MCQ आएगा. Carbetocin is what? Oxytocin antagonist, oxytocin agonist. It is basically a oxytocin like action. It is a oxytocin derivative. It has action like oxytocin only, but more powerful, and mainly the advantage, stable at room temperature. Yes or no? Can I proceed further? So this is all which you wanted to know. Carbetocin can be given. Mainly it is given prophylactically. No, beta. If you read the medicines, इस पे लिखा होता है store below 25. Okay, most of the medicines. So it will differ from this to this. So, and certain drugs में लिखा होता है do not freeze. So never keep it in the freeze. Even your vaccines also, that PSM will teach you 4 to 8 degrees. So अपना fridge का temperature 4 degree, 8 degree. If you put it in the freezer, there can be a problem. Okay. बाकी normal medicines, which is your antacid and all that, if you keep it in the fridge, but basically it's written जो temperature हो रखना. Okay, so mainly for prevention and treatment of PPH also you have to give it. Keep in mind. It is 100 microgram dose, mainly for prevention, prophylactically we give, but also for treatment we can give it. It is, I repeat, stable at room temperature, stable at RT I'm writing, okay? Stable at RT, room temperature. It's a heat stable derivative. It is a heat stable oxytocin derivative. Okay. Chalo, moving ahead, very important, very important. We are now going to discuss the topic which was not, which we left it yesterday, and that is, just a minute, okay, that is the malposition. Okay, malposition, just a second. Okay, now can anybody tell me breach is the most common malpresentation, and when I say the word malposition, what are we talking about? क्या part deliver होगा? When I say malposition, what will come out first? Okay, and what is the most common malposition? Anybody? What is the most common malposition? Okay, so please understand this, that when it is a head, it is called as vertex delivery. Very good. So vertex में होता है occipito anterior, which is normal. Occipito anterior is normal 90% of the time, but when it is occipito posterior 10% of the cases, that is called as माल पोजीशन. सो कॉन्स्टेंटली आपको ये टॉपिक में याद रखना है कि हेड डिलीवरी, इट इज अ हेड डिलीवरी, इट इज वर्टेक्स, एंड इन दिस रिमेंबर देयर कुड बी LOP also and ROP also, but ROP is 5 times more common than LOP. So ROP, अगर OP all of you correct, yes, OP all of you correct, बट अगर स्पेसिफाई किया LOP ROP, प्लीज मार्क ROP. Okay, so ROP, so most common malposition occipito posterior, and ROP much more common than LOP. Okay, now all of you please pay attention. The orientation extremely important. The outer circle, okay, the outer circle is the pelvis. Very good. उसके अंदर, सर्कल के अंदर और एक सर्कल which is the fetal head. Constantly remind yourself कि ये head delivery है. Okay, this inner circle is the fetal head. Clear? Now, same as our this, everybody knows what is anteriorly. यहाँ पे क्या है, क्या लिखेंगे? Pubic symphysis. And यहाँ पे लिखेंगे SP, sacrum या sacral promontory. All of you know this is anterior, this is posterior. Clap if you feel happy and remember. Now, ये दिखा दिया था LOA, ये तो ROP. I will right now, we will now discuss ROP. ROP, LOP same things होगा. ROP, LOP same outcome, but I will right now discuss labor in ROP. And ROP का मतलब ये है कि somewhere before the beginning of labor, somewhere in your clock hand, the occiput is at 7 o'clock, 8 o'clock. Do you agree with me? ये है आपका 12 o'clock, ये है 3 o'clock, ये है 6 o'clock, और ये है 9 o'clock. Do you agree with me? So somewhere between 6 and 9, somewhere in this zone, somewhere between 6 o'clock and 9 o'clock, when the occiput is there, 7 o'clock, 8 o'clock, we call it ROP. Is this understood to all of you? Why I call it ROP? Because right and left is in relation to mother. Okay, so if the occiput is here, we call it LOP. Do you agree with me? Yes or no? ROP, LOP, outcome will be same. Okay, is it understood? Can I get, is the orientation clear? And this is the fetal head. This is the baby ka head. Fata poster, nikla hero या nikla heroine. Okay, from here the delivery will take place. Now please pay attention, very important. Any occipito posterior, very fascinating. Any occipito posterior, 5 outcomes are possible. कितना? Repeat after me. 5 things हो सकता है. 5 things हो सकता है. 3 times the patient will land up with LSCS, and 2 times vaginal delivery, VD, all of you know, is possible. 3 plus 2 is 5. Clear? 5 things can happen. Out of the 5 times, 3 times we will have to do LSCS, and of course 2 times a vaginal delivery ho jayega. Crystal clear? Okay, now see, it will depend. Now, what is the golden rule of the pelvis? What did I tell you? When is the vaginal delivery possible? What position? Tell me in the chat box. What position is vaginal delivery is only possible when the occiput is in the, कल बताया था, vaginal delivery is only possible if the occiput is in the midline. So can you tell me, आपके घड़ी के as per your clock, which o'clock position अगर occiput है, then only vaginal delivery will take place. Yes, one more, Nivya, 12 o'clock and midline, मतलब 12 o'clock and 6 o'clock. Yes, 12 o'clock is occipito anterior, but it can also come, okay. So here automatically you know that 2 times when the vaginal delivery will take place, the occiput will either be at 12 o'clock or occiput will be at 6 o'clock. Crystal clear? Nobody will teach you like this. Okay, is it clear? Okay, sir, 2 times when vaginal delivery will take place, the occiput will be at 12 o'clock or 6 o'clock. Okay, simple. Now please pay attention. As I said, 5 outcomes are, it all depends on the patient luck. Outcome number one, or first scenario, there is a long anterior rotation. There is a long anterior rotation, and from here, the occiput will rotate and come over here. Very good. That means, sir, it and gets converted to occipito anterior, and of course a vaginal delivery will take place. मतलब के God is great. It was problem auto correction. समझ में आ गया कि आपको लग रहा था पेपर विल बी टफ लेकिन पेपर एकदम सिंपल. ऑल ऑफ यू पास. ओके, इज इट क्लियर? सो व्हाट आई मीन इज के ऑन इट्स ओन yes, it was occipito posterior. Just give me a minute. Yes, now on its own, God is great का मतलब क्या है कि yes sir, there was a problem to begin with, there was occipito posterior to begin with, लेकिन on its own auto correction हो गया, OP converted to OA and vaginal delivery takes place. Is it clear? So the first outcome which all of you know is conversion to occipito anterior, and of course the occiput is at 12 o'clock and a vaginal delivery will happen. Okay, unless there's some other problem. Okay, is it clear? सेकेंड आउटकम ध्यान से सुनेंगे. शॉर्ट एंटीरियर रोटेशन मीन्स सर नाउ द ऑक्सिपुट will rotate only till 9 o'clock. Short. It will rotate anteriorly, but only till 9 o'clock. And occiput rotates till 9 o'clock. Head will come down, but will get stuck at the level of ischial spine. Ischial spine is station 0. Okay, ischial spine is station 0, and sagittal suture will run from 9 o'clock, because if occiput is over here, sagittal suture runs from 9 o'clock to 3 o'clock, and this is called as what? Deep transverse arrest. ध्यान से सुनेंगे, what is the meaning of deep transverse arrest? Deep because it is deep in the pelvis at the level of station 0. What is station 0? In half an hour I will teach you when I teach you forceps. अभी खाली याद रखो कि हेड जो है, बच्चे का हेड ischial spine के लेवल पे अटक गया है. At the level of ischial spine the station is 0. So head is where? At the level of ischial spine, and occiput is where? At 9 o'clock. So it is called as deep transverse arrest. Wherever the last word is arrest, my dear student, we will go and do LSCS. Is this understood to all of you? The first outcome here, deep transverse arrest. I repeat, whenever if they tell you that deep transverse arrest का मतलब क्या है कि सर occiput is at 9 o'clock. Clear? Occiput is at 9 o'clock and head is at the level of ischial spine. Ischial spine मतलब station 0. Okay, तो station 0 and further descent is not coming. बस उधर head अटक गया. Head is stuck at station 0. Further descent will not take place. This is called as deep transverse arrest. Second, all of you pay attention. Occiput will not move only. Okay, so now please pay attention. What I told you, simple rule. Vaginal delivery only possible when the occiput is at 12 o'clock or 6 o'clock. Clear? If the occiput is anywhere else, my dear student, if they tell you occiput is anywhere else, 3 o'clock, 9 o'clock, 7 o'clock, 8 o'clock, अगर anywhere else, ये 12 and 6 छोड़ के occiput is anywhere else, we will have to do LSCS. Is this understood to all of you? Let the occiput be at 3 o'clock, 9 o'clock, 7 o'clock, 8 o'clock. Then I will have to do LSCS. Crystal clear? Yes or no? Because vaginal delivery तभी होगा 12 o'clock and 6 o'clock. Okay, is this understood to all of you? Yes. So second outcome is DTA. Now next, occiput will not rotate only. Occiput जहां है वहीं खड़ा रहता है. So this is called as, and the sagittal suture runs like this. This is called as oblique. Why oblique? Because you can see sagittal suture oblique है. Posterior arrest. Oblique posterior arrest. What do I do again? LSCS, because occiput is where? Occiput is at 7 o'clock. Yes or no? ये 6 है, तो 7 o'clock या 8 o'clock के बीच में occiput है. Occiput is at 7 o'clock or 8 o'clock, because 6, 7, 8, 9. Clear, all of you? Yes. So again, oblique posterior arrest. Oblique posterior arrest. Now the last part. Occiput will rotate posteriorly. Occiput rotate हो गया posteriorly. Occiput will rotate posteriorly. So now occiput and sacrum आमने सामने है. Correct? Now all of you pay attention. Here two things can happen. What I told you, okay, sir, when the occiput is in the midline, vaginal delivery is possible, but that does not mean vaginal delivery will always take place. So if after pushing also, if the vaginal delivery does not take place, 2 hours हो गया, 3 hours हो गया, you tell the patient you have a occipitosacral arrest, and again I will have to go and do LSCS. Don't worry, I'll repeat everything in 2 minutes. So the last outcome here is occipitosacral arrest. I repeat, occipitosacral arrest. Why? So can you appreciate last word arrest? Do LSCS. See, deep transverse arrest, LSCS. Oblique posterior arrest, LSCS. Occipitosacral arrest. अरेस्ट मतलब के फर्दर डिलीवरी इज नॉट टेकिंग प्लेस. ओके, एंड द लास्ट जो मैंने कल बोला था कि वर्टेक्स ओपी, फेस टू बेबिस वर्टेक्स ओपी, जैसे मैं नेम सर नेम, ऑल ऑफ यू हैड रिपीटेड 5 times कि सर if the occiput is at 6 o'clock and if there are good strong contractions and a favorable pelvis like an anthropoid pelvis, there will be a phase to pubis delivery. What is the phase to pubis delivery? All that I'll explain to you in 2 minutes. So phase to pubis delivery is a vaginal delivery. Okay, when the occiput is at 6 o'clock, there is a possibility of and the vaginal delivery which takes place is called as phase to pubis delivery. Okay, very good. इसका मतलब क्या है? All of you now please pay attention. All of you please pay attention. Okay, all of you please pay attention. Okay, कि normally क्या होता है? All of you look on the board. Normally isn't, and I'll show you with the picture and diagram. Okay, normally the occiput आगे होता है. Correct. So this is the fetal head. This is the fetal head. Yes or no? ये nose, ये mouth, like this, ये eyes. Okay. And occiput, all of you know, occiput hinges below the pubic symphysis and the baby will come out like this. Baby is in the sacrum hollow. Yes or no? This is sacrum posterior. So do you agree with me? This is occipito anterior. Do you agree with me? ये fetal head है. यहाँ से हम वजाइना का ओपनिंग हम पीवी करते हैं. ओके, ये वजाइना है. ओके, वजाइना का ओपनिंग है और ऐसा बेबी बाहर आएगा तो उसको बोलते हैं ऑक्सीपिटो एंटीरियर. यस और नो? नाउ ऑल ऑफ यू प्लीज पे अटेंशन ओवर हियर. ओके, इज दिस अंडरस्टूड टू ऑल ऑफ यू? I am not, just 1 second, beta. I am not able to get your doubt, Mazur. Okay, first you listen to me, all your doubt will get clear. Okay, I am just writing ROP, more common compared to LOP. Ha, now see all of you. And I'll show you with position and diagram, don't worry. Now, phase to pubis delivery का मतलब क्या है? Phase to pubis delivery का मतलब है, face faces the pubic symphysis before coming out. Face faces the pubic symphysis before coming out. मतलब क्या है sir? This is the pubic symphysis. मतलब anterior. And this is the baby का nose, mouth and the eyes, and like this. Okay, eyes. So, and this is the occiput. Okay, so now occiput is where? Sir, occiput is पोस्टीरियर 6 o'clock, बिकॉज ये आपका सेक्रम है ना, तो यहां पे हो गया ऑक्सीपिटो पोस्टीरियर. और जब ये बेबी बाहर आएगा, ये बेबी बाहर आएगा, सो इट इज अ वर्टेक्स. एंड फेस कहां देख रहा है सर? फेस इज फेसिंग द प्यूबिक सिम्फाइसिस. मतलब के सर सपोज दिस माई हैंड इज द प्यूबिक सिम्फाइसिस, this my knuckle is the baby's face. All of you look over here, and this is the baby head. It happens like this, like this, like this. So the face is facing the pubic symphysis. Face faces the pubic symphysis. Face faces the pubic symphysis. That is called as face to pubis delivery. Thoko tali. Is this understood to all of you? Again, I will explain to you. Don't worry. Simple. Dhyan se suno, then I'll revise also. Suppose all of you are the baby. Okay, all of you are the baby in the vaginal canal. Now ceiling anterior, ground posterior, correct? 12 o'clock, 6 o'clock. So if I tell you make your occiput, all of you look to the ground. All of you look to the ground. So occiput is where? Occiput is anterior. बराबर, वो normal हो गया. But now if I tell all of you make your occiput at 6 o'clock. If I tell you make your occiput at 6 o'clock, I will have to do like this. Do you agree with me? 10 thumbs up. Because then only when I look like this, my occiput is facing the ground. Yes or no? So if my occiput is at 6 o'clock, where is automatically the face looking? Face is looking at the ceiling. Ceiling matlab 12 o'clock. 12 o'clock matlab pubic symphysis. Thoko tali. तालियां बजते रहनी चाहिए. Clear? कि sir face faces the pubic symphysis before coming out. Okay? Is this crystal clear to all of you? Is this understood to all of you? I repeat, I repeat. I repeat, what is the meaning of face to pubis delivery? Sir, face faces the pubic symphysis before coming out. मतलब के जस्ट रिमेंबर दिस पिक्चर, ओके, कि सर दिस पिक्चर अगर है, ये वजाइना से हेड बाहर आएगा तो आपका ऑक्सीपुट इज टुवर्ड 6 o'clock. सो ऑटोमेटिकली जस्ट रिमेंबर वन थिंग, व्हाट इज फेस टू प्यूबिस डिलीवरी? Sir, face to pubis delivery is a vaginal delivery which takes place when the occiput is at 6 o'clock. Is this understood to all of you? So, face to pubis is a vaginal delivery. This one line will, nobody will summarize this in only one line except me. Face to pubis is a vaginal delivery. Yes. Not exactly stargazing beta, but looking at this. Stargazing is a word used for breach, but something similar. Yes. Stargazing में थोड़ा oblique होता है. It directly एकदम bang at 12 o'clock. Star, you look like this. Okay. Yes. So vaginal delivery, face to pubis is a vaginal delivery which will take place when the occiput is at 6 o'clock. Okay, so vaginal delivery भी आ गया, occiput 6 o'clock आ गया. So if automatically if the occiput is at 6 o'clock, the face faces the pubic symphysis का posterior aspect. Okay, ये जो pubic symphysis है, ये जो pubic symphysis है, उसका पीछे का पार्ट को बेबी देखते देखते बाहर आएगा. Okay. Is this understood to all of you? Again with picture I'm showing you. So all of you, please pay attention. This is the summary which I am telling you. In case of vaginal delivery, we have discussed 6 o'clock OP. No, 6 o'clock OP and face to pubis is directly getting delivered without any rotation. In this statement, no, nothing, no, beta. Two things. Of course, rotation has to take place. Okay, rotation will take place na, because the occiput at beginning is where? Occiput is beginning at 7 o'clock or 8 o'clock. So where will the rotation take place? That is luck. It can rotate anteriorly. तो conversion to occipito anterior and it can rotate posteriorly. Clear मजूद? तो रोटेशन होगा. फिर 6 o'clock के आने के बाद भी अगर अटक गया तो यू कॉल इट एज ऑक्सीपिटोसेक्युलर अरेस्ट. बट अगर 6 o'clock पे ऑक्सीपुट पहुंच गया and if the delivery takes place, it has to be a face to pubis delivery. Is it clear? So rotation is taking place, internal rotation is taking place. It depends. So now you only tell me. Okay, so this is the 5-star slide. Please remember all the 5 outcomes. I'll repeat also. DTA, oblique posterior rest, occipitosacral rest, and occipito anterior 6 o'clock. So the last thing, all of you, again to summarize, okay, sir, in occipito posterior we have got LOP, ROP, 5 outcomes are there. Now chalo tell me, what will happen if it is a long anterior rotation? If it's a long anterior rotation, that means, sir, OP became OA, and of course a vaginal delivery will take place. Very good. Now LSCS के जो आउटकम है शॉर्ट एंटीरियर रोटेशन, तो क्या होगा? शॉर्ट एंटीरियर रोटेशन मतलब ऑक्सीपुट विल कम एट शॉर्ट एंटीरियर रोटेशन विल गिव राइज टू डीप ट्रांसवर्स अरेस्ट. शॉर्ट मतलब डिस्टेंस कम है ना, ये देखो ये लंबा डिस्टेंस है, दिस इज लॉन्ग डिस्टेंस. यस और नो? दिस इज अ लॉन्ग डिस्टेंस, ये लंबा 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 लंबा, तो इसको बोलेंगे लॉन्ग रोटेशन. और ये वाला छोटा. यस, सो दिस इज अ लॉन्ग रोटेशन, लॉन्ग anterior rotation, and this second one is called short anterior, and this is called posterior rotation. Yes, very good. अब जाके समझ में आ गया. Okay, so short anterior rotation giving rise to DTA. Second, non-rotation मतलब ऑक्सीपुट उधर से हिलेगा ही नहीं. नॉन रोटेशन तो oblique posterior arrest. And last one, posterior rotation, and still there is, yes, it can happen. Sir, agar posterior rotation ho gaya and suppose the pelvis is not favorable, posterior rotation, so occiput comes at 6 o'clock, but still there is a arrest which is called as occipitosacral. So ho sakta hai. It's not that, because I told you when the occiput is at 6 o'clock, vaginal delivery is possible. It's not that it will always happen. So after pushing, also delivery is not taking place, you tell the patient, ye ho gaya aapka occipitosacral arrest. Yes, occiput will be at 6 o'clock. So just remember, my dear student, when the occiput is at 6 o'clock, two outcomes are possible. Either delivery nahi hoga, to hum bolenge OSA, and delivery hoga, to it has to be a face to pubis delivery. And the last thing, as I said, okay, sir, there is again a posterior rotation. So occiput now, okay, posterior rotation. So occiput is at 6 o'clock, and if it's a suitable pelvis with very strong contraction and a favorable pelvis like an anthropoid pelvis. Okay, remember anthropoid pelvis. Okay, details you're not supposed to remember, but anthropoid pelvis favors the face to pubis delivery. Okay, is this understood to all of you? Is this understood to all of you? Yes. Okay, so these are all the 6 outcomes, all the 5 outcomes. All of you should know it by heart. And what is face to pubis delivery? Face faces the pubic symphysis before coming out. Okay, the last thing, which to again show you the image so that it becomes absolutely crystal clear, all of you. Yes. Can all of you now see this? All of you, please pay attention. First, this is normal. This is normal because this is occipito anterior. Can you see this? ये pubic symphysis है. Occiput कहाँ पे है? ये वाला picture is occipito anterior. See the baby face. Face is in the sacrum hollow. This is the sacrum. So this is posterior. This is the pubic symphysis, and you can again see over here, this is the pubic symphysis, this is the sacrum, and you can see occiput is over here. So this is normal for comparison. But abhi ye wala dekho picture, ye kya hai? Sir, here this is the posterior, and the head dekho baby ka kahan pe hai? Where is the occiput? Can you tell me where is the occiput? Sir, the occiput is towards the sacrum. So this is occipito-posterior. It becomes head or vertex. When I do the PV, it is vertex. Okay, and I repeat, do not confuse this with face. Face में face दिख रहा था, yes or no? So is it clear? Face and face to pubis are completely different. कल बताया था, isn't it? ठोको ताली. See, face delivery and face to pubis delivery are same. Sorry, sir, it is false. They are completely different. Because sir, face में ये है, ये face है. Okay, superb. Yes. Okay, yes. So when I again show you the last picture, all of you will now become crystal clear. Okay, sir, suppose this is the baby's position. The occiput is posterior, and now when this delivery will take place, baby ka face kahan pe dekhega? Isn't it? Face will look at the pubic symphysis. So face to pubis delivery can take place. Is this understood to all of you? Face faces the pubic symphysis. Matlab, if this delivery takes place, this will be a face to pubis delivery, vertex OP. Didn't I tell you? Face to pubis में क्या याद रखना है? खाली दो चीज, vertex OP. Simple. Is this clear to all of you? Okay. Is this crystal clear to all of you? So face to pubis delivery is a delivery which takes place when the occiput is at 6 o'clock. Okay, so खाली इतना याद रखना है माल पोजीशन में कि सर any of the 5 outcomes can take place. It depends on the luck, anterior rotation, posterior rotation, all that, and phase to pubis is the vaginal delivery, which will take place when the occiput, when the face faces the pubic symphysis. Okay, yes, excellent. Now moving on to a very very important topic again on this. Surely the question comes, and that is, we come back to this later in a minute. Just a minute, my dear students. Yes. Okay, now instrumental deliveries, which is forceps and vacuum. Again, one MCQ for sure surely comes in this topic. Now, can you tell me when to apply? What are the indications? Why should I apply the forceps and vacuum? कब लगाते हैं? What are the 3 main reasons why we apply a instrumental delivery? Chalo. What are those? One is fetal distress. One is fetal distress. Chalo students, tell me. Second one is mother is pushing. Mother is pushing, but there is no delivery. हाँ, very good Lipsa. हाँ, Masood मतलब more, no, not more baby weight. Okay, yes, very good Vijaya. So maternal exhaustion. And lastly, I will tell you, Masood वो क्यों नहीं करना है, more kg weight क्यों नहीं लिखना है. Okay, so one is fetal heart rate is dropping down at full dilatation. We'll discuss that. Second is maternal exhaustion, and third is prolonged second stage. Okay, not only prolonged labor, prolonged second stage. मतलब के after 2 hours, 3 hours also the delivery is not taking place, prolonged second stage. Or we'll discuss in the next topic, heart disease, cut short second stage. Okay, what is the meaning of cut short second stage? I will explain to you in detail, don't worry. Cut short second stage का मतलब क्या है? If the patient is fully dilated, she will deliver. Anyway, baby delivery हो जाएगा, but I don't want mother to do too much of pushing. Because in that heart disease, okay, mainly that is in heart disease patient. I'll tell you why. Because in heart disease patient, you don't want the mother to bear down too much. So that's called cut short second stage. Is this understood to all of you? Now, please understand this. इसमें क्या याद रखना है? Do not mark CPD as the indication. Very common mistake, Masood, okay, which many students make a mistake. They say कि sir cephalopelvic disproportion. Common cephalopelvic disproportion मतलब baby is very big, jumbo, ये head है. Okay, baby ऊपर है, head. Elephant, छोटा हाथी. Okay, 4 kilo, 5 kilo. Okay, so big baby है. And there is no space only for the baby to come out. Okay, so now tell me, इसको बोलते हैं cephalopelvic disproportion. Cephalo मतलब head, pelvis मतलब के जगह नहीं है. There's no space for the baby to come out. What he was trying to tell me is, sir, excessive weight. Okay, now tell me, is there space for the baby to come out? No. So what is the point of putting all these dangerous instruments and pulling the baby out when there is no space only? इज इट क्लियर? तो ये केस में क्या करेंगे सर? ये केस में वी प्रिफर टू डू LSCS. इज दिस अंडरस्टूड टू ऑल ऑफ यू? So please remember, my dear student, very important take home message. Do not do, yes, very good. Okay. Do not mark CPD as the indication. CPD is not a indication. In fact, it becomes a contraindication. Is this understood to all of you? It is a contraindication because for instrumental delivery, one of the prerequisites I will tell you, pelvis should be adequate. Pelvis should be adequate. Pelvis should be adequate का मतलब है कि there should be no CPD. समझ में आ गया? Is this crystal clear to all of you? 5 thumbs up. कि कुछ भी मार्क करो, CPD मार्क मत करो. सो फीटल डिस्ट्रेस, प्रोलॉन्ग सेकंड स्टेज, मैटरनल एग्जॉशन, कट शॉर्ट सेकंड स्टेज. Okay, now very important, the important differences between forceps and vacuum. Anybody which has between the two, okay, both can cause damage to both, which has got more maternal complication, which has got more fetal complication, which can cause more trauma to whom? So vacuum cup I apply only on the fetal head. Okay, where on the fetal head also I'll tell you, virgin MCQ. So when I pull the baby, mother, very well, mother का कोई tissue नहीं है, but when I pull the baby, cephal hematoma, scalp laceration, retinal detachment, all that much more with vacuum. Forceps, the baby is very well protected in the forceps cage. So when I pull the baby out, baby safe, but mother, all the mother, cervical laceration, perineal tear, cervical tear, 4th degree perineal tear, mother ka injury, maternal injury, more with forceps. Okay, is this understood? Matlab may happen. It's not that always it will happen, but it can happen. Okay, now remember, my dear student, the most important point, that forceps I can only apply when the cervix is 10 centimeter. It means full dilatation. Compulsory. Vacuum also preferred at 10 centimeter only, but theoretically, theory wise, we can apply it at 7 centimeter or more. Okay. Practically we wait for full dilatation only, but theoretically 7 centimeter पे लगा सकते हैं. Okay, now tell me, between the two, which is faster? Between forceps and vacuum, which is faster? Any idea? Between the two, which is faster? Yes. Why? Because you will take a forceps one blade, second blade, lock and pull the baby out. So forceps is faster. Why? Because a vacuum, after applying, I cannot start immediately pulling the baby. I have to wait for some time. I have to wait for some time for the pressure to build up. So fetal distress agar hai, if it is fetal distress, this is preferred. This instrument is preferred. Fetal distress mein less preferred. It's not that I can't apply, less preferred, because vacuum will take some time. Okay, हाँ बेटा वो आएगा ना नवीन, पिक्चर अभी बाकी, हाउ मच प्रेशर टू यूज वैक्यूम सब आएगा. Okay, सब बताएंगे आपको. Okay, now suppose it is a preterm baby. Suppose it is a preterm, prematurity. मतलब के suppose we have a patient who is say 33 weeks, 34 weeks, and I need to apply an instrument. Suppose, then which I can apply and which I cannot apply. 34 weeks, even 35 weeks, ऐसा. Which, what do you think? F or V? Yes, sir, forceps is okay, but vacuum absolutely contraindicated in prematurity because I told you, okay, sir, vacuum in preterm will cause more intraventricular hemorrhage. Okay, and coming to the question in vacuum, the negative pressure, please you have to by heart this figure. 0.8 kg per centimeter square, roughly corresponding to 500 to 600 millimeters of mercury. Okay, so please pay attention. Okay, is it clear, Naveen? आपका ये डाउट होगा कि 600 millimeters of mercury, 0.8 kg per centimeter square. Now ध्यान से सुनो, cervix should be fully dilated, minimum 7 centimeter. Already told to you, less fetal but more maternal complication, more fetal. Already told to you. Preferred in fetal distress, less preferred in fetal distress. Now all of you tell me, कल जो बताया, anybody, face presentation, which instrument can I apply? अगर face है and face में that also you know mento anterior because mento posterior goes for LSCS. So अगर face है, okay, apubic symphysis, so mento anterior face, and suppose there is a requirement, suppose it's mento anterior face and mother exhausted or heart rate dropping down, which yes, I can apply only forceps. Vacuum, if I apply, eyeballs will pop out. Yes or no? हाँ, vacuum आप लगाओगे face पे क्या होगा, आंख बाहर आ जाएगा. So face presentation, forceps okay. Similarly, after coming head of the breech, head is inside, breech is outside. One special forceps I told you yesterday. So when the head is inside and the breech has already delivered, which one special instrument I told you we can apply for the after coming head? Piper's forceps, thoko tali, talia bajte rehni chahiye. So Piper's forceps can be applied. Common sense, I can only see the baby's bum. I can't apply vacuum on the baby's bum. Head to andar hai. So clap if you feel happy. V for vacuum, V for vertex. Vacuum is only for vertex presentation. You can see can be applied on face and after coming head of the breech, cannot be applied on face and after coming head of the breech. Is this understood to all of you? Now, okay, very important. Please pay attention, all of you. Very important. What is the meaning of the word station? Anybody, can you tell me what is the meaning of the word station? What is station? So station is not your railway ka station या metro ka station. What is the meaning of the word station? Sir, do forceps cause any? No. Injury can happen, but very rare. It's a safe thing, okay? But you have to be very careful. Yes, see, of course, complication can happen. So when you apply excessive force, there can be problem, mainly maternal thing. But forceps may, if it is not applied properly, sometimes then this facial, now excessive compression and injuries, yes, rarely, if it's not applied properly. Okay, now अभी और differences बाकी है, but उसके पहले what is the meaning of the word? Yeah, so this you know the indications I told you. Indications for the instrumental delivery. Okay, but CPD is a contraindication. Now what is the meaning of the word station? तो station का मतलब क्या है? All of you please pay attention. Station is the relation of the fetal head in relation to the maternal pelvis. Compulsory for station, I have to do a PV examination. Okay, station I can only find out on PV, not on per abdomen. Anybody? What is the landmark? What is the landmark? Ischial spine is station 0. Okay, so ischial spine is station 0 and उसके ऊपर 1 सेंटीमीटर -1 -2 -3 -4 -5. Okay, and 1 centimeter down +1 +2 +3 +4 +5. Clear? Same thing on this side also. -1 to -5 +1 to +5. Crystal clear? Now स्टेशन कैसे पता चलता है? इट इज व्हेन यू डू अ पीवी इन लेबर. सपोज यहाँ पे फीटल हेड है, फीटल हेड इज ओवर हियर. Okay, so you touch the, you go inside, just follow the laser. Okay, so you go inside, you do a PV, you go inside, you touch the fetal head. फिर fetal head के बाजू में से just slide your finger, just move your finger and just swipe your finger over here. You swipe your finger over here, so you will get this prominent bulge, which you will say कि ये 0 है, and then just estimate कि how much this head. Okay, you will say कि head is over here, leading point of the head is somewhere over here, so ये head roughly around, you will say कि okay, head has come, and this वो guy, when you do 100, when you do 10 times PV, you will come to know. Okay, this is like 1 centimeter, 1 centimeter. So sir, from the clinical estimate, I know that the fetal head is over here, so the station is +2. Is this understood to all of you? It is, I repeat, it's a clinical judgment, a relation of the fetal head in relation to the maternal ischial spine. You put the hand in the vagina, swipe your finger and roughly see okay, below this prominent ischial spine how much the head has come down, 1 centimeter, 2 centimeter. Okay, now one of the most important statements of my whole lecture in modern day obstetrics, ध्यान से सुनेंगे. When the station is +2, when the station is +2 and if I apply the forceps, this is called as low forceps. क्या बोलेंगे उसको? Low forceps. And when the head is further down, +3 +4, मतलब almost the scalp is visible. Okay, station more than or equal to +3, or they say that the scalp is visible, मतलब crowning के just पहले. Okay, crowning के पहले you can see the fetal head, scalp is visible, and then you apply the instrument. This is called as outlet forceps. Crystal clear to all of you? And one of the most important statements of my whole lecture is that in modern day obstetrics, station should be at least +2. Station should be at least +2 before I apply a instrument. मतलब के my dear student, you will only mark forceps or vacuum as the answer if the station is +2, +3, +4, +5. Are you getting my point? बाकी जो भी दिया है पुराने जमाने में जब स्टेशन was 0, forceps mid cavity, और स्टेशन जब ऊपर था high forceps, all that is outdated kachra dustbin. We don't apply high forceps and mid cavity forceps because lot of injury to the mother. This +2 MCQ was asked also recently in FMG examination and likely to be repeated. के minimum station कितना होना चाहिए? Sir, at least +2 and below. So station should be more than or equal to +2. Then only you will mark. forceps or vacuum as the answer. Is this understood to all of you? Clap if you feel happy. मतलब low forceps can be applied, outlet forceps can be applied when the station is +4 +5. You low down +4 +5 तो हम outlet forceps बोलेंगे, +2 we call it low forceps. Is this understood to all of you? Because if you when the station is very very high, if you apply the forceps, they are going to cause more complication, so you don't do, and you prefer to do LSCS. Okay, so either you wait for the station to come down, or you will have to, if the station is very high, you will do LSCS. So now tell me the answer, my dear student. Such kind of clinical cases have already started coming in the NEET PG and will also come next year, 2 years in FMG examination. Two separate cases, two separate long clinical case. They will tell you a big story. Okay, primi gravida, 38 weeks. Okay, pushing for the last 2 hours. Okay, pushing for the last 2 hours. Exhaustion, dehydration, fetal heart rate सब बता देंगे. I'll tell you how. Okay, वो भी fetal heart rate is dropping down to 100 per minute. Okay, सब देंगे, pulse, BP, all that. And लिखा होगा, of course, PV पे she is fully dilated 10 centimeter and station is +3. What next? Wait and watch. LSCS forceps. Anybody, what is your answer? Primi gravida, 38 weeks, pushing for the last 2 to 3 hours, getting dehydrated, exhausted, and fetal heart PV already fully dilated, station +3, and baby heart rate dropping down to 100. What will I do? Yes, sir. Since the station is +3, we will go for forceps. But the same MCQ होगा, and एक डांडी का फर्क, station is now -3. Now, what is your answer, my dear student? Okay, sir, mother is exhausted and the station is -3. -3. तो क्या करोगे all of you? Yes, excellent, all of you. Super. Thoko tali. Sir, now when the station is -3, forceps can't be applied, vacuum can't be applied, and I will go for LSCS only. Because why? Because the fetal heart rate is dropping down. There is fetal distress also. Fetal distress is there. Maternal exhaustion is there. But the station is still very high up. You cannot wait and watch. You will go for LSS. Clap if you feel happy. Okay, so like this kinds of questions are surely coming in the exam. And clap if you feel happy. Only one sign different. What is the difference between the two MCQ? Sir, both the MCQs are absolutely cut, copy paste similar. खाली difference is in this one sign, +3 and -3 का फर्क है. Okay, is understood. That's why my open challenge, whatever books you read, till the time you listen to my lectures, you can't get this MCQ correct. Students वही बोलते हैं, सर वो ग्रैंड टेस्ट दे रहे हैं, समझ में नहीं आ रहा है, कभी आंसर दिया है फोर्सेप्स, कभी दिया है LSCS. अभी ये कॉन्सेप्ट है, समझ में आ गया. I repeat, your station should be at least +2, and of course this point I will also repeat. Okay, is it crystal clear to all of you? So differences pata chal gaya. And this also I told you, this is our forceps, this is our vacuum. Okay, sir, can be applied on preterm fetus, contraindicated on preterm baby because there is increased risk of intraventricular hemorrhage. If the fetal heart rate is normal, fetus is Naveen, fetus is not, you don't say fetus is at 3 centimeters, you say fetus is at station +3, then you can wait. Okay, if the heart rate is normal, if the baby heart rate is normal and there is no maternal exhaustion also, then you can wait. Okay, is it clear, Naveen? Don't say first 3 centimeters, say station is +3. But agar Okay, Naveen, if the station is +3, but so you said heart rate normal, so there is no fetal distress. But if there is maternal exhaustion or this, then also you will apply. Okay, so if any of the indication is fitting, you can apply. Samjha? So whole scenario you have to say. If fetal heart rate is also normal, maternal exhaustion is also not there, and it is not heart disease and you don't want to cut short, then of course you will wait. Like she just become fully dilated for half an hour. Wait. Let the head come down on its own. Na? Is it clear? Then you don't apply. Unless if the mother says, doctor, I am exhausted, I can't push. Please help me out. Then you apply. Okay? Clear? So the whole picture you have to see. Any one of them, either fetal distress or maternal exhaustion or any one of them. It's not that all three have to be present. Okay. Now all of you pay attention. Very important. What are the already I told you 3-4. What are the prerequisites for forceps or vacuum? And the last part, very important, logic. Tell me, suppose I apply the instrument and the blade is not fitting properly, or the blades are not locking, or even after pulling the head is not coming down, then what backup should be there? What do I do if the instrument can fail? It's not 100% guarantee. So if the forceps vacuum fail, what can be done? If the forceps or the vacuum fail, what can be done? Any idea what backup should be there? Very good. Okay, if the instrument fail, whenever we go for any instrumental delivery, three things should be kept in mind. Okay, sir, when we are applying the instrument, yes, LSCS backup should always be there, and that is why not only LSCS backup, matlab not only gynecologist, operation theater, anesthetist, all that has to be there. Okay, so all of you please pay attention. This is extremely important. This is the prerequisite for forceps, but mainly also applicable to vacuum. The cervix must be fully dilated. Yes or no? 10 centimeter. Yes or no, my dear student? दूसरा बात all of you start it. Okay, the station should be at least +2, more than or equal to +2, and either it can be a vertex, or if it is a phase, then mento anterior. This is mainly for forceps, of course. This okay, and the membranes have to be ruptured, and most important, there should be no CPD. Didn't I tell you pelvis should be adequate? So खाली तीन चीज याद रखना है: adequate pelvis, fully dilated cervix, and station +2. Of course, bladder empty, consent you will take of the patient, an experienced operator, understood, valid indication, understood, and a pediatrician also there, understood, and your backup plan in case of failure, LSCS facility has to be there. Is this understood to all of you? Okay, so this is a 5-star slide. Please by heart these questions are surely come. It's a revision of what I told you. Main khali teen hi yaad rakho. Okay, cervix fully dilated, station +2, and membranes of course have to be ruptured, then only I can, and adequate pelvis. Adequate pelvis +2 station, full dilatation. Consent is understood, experienced operator, pediatrician, and LSCS backup is also logical and understood. Is this crystal clear to all of you? Yes. 2-3 more points. Anybody? What is Chignon? What is Chignon? Okay. Can you see this सुपांडी का cap के जैसा? तो Shignon, this is your silastic cup. This is the metal cup. This is nowadays preferred. And Shignon is the artificial caput. It is the artificial caput which gets formed during vacuum delivery. Nothing is to be done. It will, you just have to wait and watch. No treatment. It is self-limit. Within one, it disappears. It's basically a edema. Chignon is an artificial caput. It's a caput which is formed. You don't need to do anything. You just need to wait and watch. It will disappear in 2-3 days time. Okay, Chignon. It is the artificial caput which gets formed during vacuum delivery. Okay, is this understood to all of you? So is it clear, Shignon? So when you apply the vacuum cup, there is a caput formation which is there, and it will resolve on its own after a few days. Okay, now very important MCQ. ध्यान से सुनेंगे. If this is the fetal head, okay, this is the fetal head. This is the fetal head. This is the posterior fontanelle. This is the anterior fontanelle. बराबर? ये हो गया आपका PF. ये हो गया आपका AF. Now, my question to all of you, where will I apply the vacuum? Okay, I'm giving you option A, option B, option C, option D, option E. कहाँ पे, where to apply vacuum? PG level. I'm so happy teaching for the last 15 years. This year NEET PG, this MCQ के. Where to apply the vacuum? A, anterior to posterior fontanelle. Chalo, I want 10 students to answer. Right, wrong does not matter. Only 3 have answered. Only when I get 10 answers, I will tell the answer. Okay, somebody saying A. Very good. Chalo, A, B, C, D, E khali likhna hai. Very good. 3 have answered. Anterior to posterior fontanelle. Okay, very good. B. Very good. Okay. Chalo. Okay, so all of you please pay attention. The important part is two things. You just have to remember one thing, that as close to the posterior fontanelle as possible, B is the answer. You can't apply over here. As close to the posterior fontanelle as possible is one answer, which is an acceptable answer. But the best answer, anybody, the best answer is what? Please pay attention. The answer is PG level MCQ, pivot point और फ्लेक्शन पॉइंट. क्लैप इफ यू हैव लर्न समथिंग न्यू. ये क्या है, ध्यान से सुनेंगे कि सर व्हाई व्हेन आई अप्लाई इन सच अ वे, व्हाट इज द बेनिफिट? ये सिंपल, लेस मैटरनल एंड फीटल कॉम्प्लिकेशन, बेसिकली सेफ्टी के लिए. सो पोस्टर fontanelle, anterior fontanelle, line joining the two is called as the sagittal suture. Now in this line, see, vacuum is a circle, बराबर, vacuum is a circle. So circle कैसे आप, vacuum is a round circle. How will I apply the vacuum is that the vacuum will be applied in such a way that the center of the vacuum cup, बराबर ये circle को center होता है, the center of the cup is on the point. This point is called as your flexion point or the pivot point. How will you do it? Sir, from this posterior fontanelle, come ahead by anybody 3 centimeter. And from the anterior fontanelle, go behind by 6 centimeter. Thoko tali. And you will get a point which is called the flexion point or the pivot point. And the center of the cup, center of the vacuum cup should be on this flexion point or pivot point. Extremely important virgin MCQ 5-star, 7-star slide. I repeat, the most important point is putting the cup on the flexion point or the pivot point. The center of the cup should be on this point. Okay. It is located on the sagittal suture 3 centimeter anterior to PF and 6 centimeter posterior to AF. And simple, क्यों करना है? Because when you do it correctly, there will be minimal injury to both mother and the baby. Okay, मतलब for safety. क्यों? Logical. Okay, तो posterior fontanelle से come ahead by 3, anterior fontanelle से go behind by 6. As I told you, this is the cup perimeter, and this point you can see clearly the center of the cup is on this flexion point or the pivot point. Clap if you have learned something new. And go an open challenge. Ask all your other students, friends who are not attending my class कि कभी pivot point सुना है, flexion point सुना है? किसी ने नहीं सुना होगा. And yes, this is absolutely coming in this next 2 years exam. Okay, is this crystal clear to all of you? Yes, 10 thumbs up. Is it understood to all of you? Have all of you understood this? Yes. Okay. I repeat very quickly. बहुत important है. The center, the simple one line याद रखना है. The vacuum cup is applied in such a way that the center of the vacuum cup should be on a point which is called as a pivot point or a flexion point. Where is this point? From posterior fontanelle, come ahead by 3 centimeter. From anterior fontanelle, go behind by 6 centimeter. Okay, and where you get this point joining on the sagittal suture, ये point हमारा है. Cup should be placed over there for maternal safety. Okay, nothing more. So 4 steps vacuum. Basically in this you need to know the indication, complication. The last point very difficult. Okay sir, suppose, very difficult. It is not at NEET PG, it is not asked in NEET PG also. Okay sir, suppose it is IUFD. Suppose the baby is dead. Suppose the baby is dead and now the mother is, see, baby dead. So fetal distress का तो सवाल नहीं है, but there is maternal exhaustion. Mother says, sorry doctor, I cannot push. My mother exhausted, or and already she is pushing, or mother exhausted, pushing for the last 2 hours. unfortunately, and of course fully dilated, 10 centimeter dilatation, IUFD, and station भी favorable है, station is +3. अभी आप wait and watch LSCS, forceps, vacuum. Now please tell me which has got more fetal complication, which is more safe for the mother, which is more safe for the mother? Vacuum, isn't it? Vacuum is safe for the mother. Okay, vacuum is safe for the, no beta, LSCS क्यों करेंगे dead baby में? Okay, IUFD, why will I do LSCS? Masood, okay, IUFD में LSCS is the last resort when the delivery is not taking place only. Is it clear? Okay, so wait and watch नहीं करेंगे, LSCS नहीं करेंगे. Why? Because why on a dead baby I will do LSCS? Dead baby I do LSCS, Masood, only if they tell you it's a oblique lie, transverse lie, all that. Okay, now all of you pay attention. Yes, the logic is कि sir baby is out of the equation, baby is dead. So baby is dead. So जो mother के लिए safe है वो apply करेंगे and student will mark vacuum as the answer. Correct, but it is wrong. Okay, sir, if it is IUFD, vacuum, yes, is safe for mother between forceps and vacuum, but the vacuum will always fail. Vacuum will always fail. Vacuum will always fail if the baby is dead. मतलब क्या है? Please pay attention. As I told you, Chignon formation. Fetal head goes inside the cup. I told you, and then when the Chignon formation takes place, then only the vacuum will build up and successful. And for Chignon, here the blood supply should be on. Dead baby, no blood supply. So what will happen? Please understand. Baby is already dead. You cannot further damage the baby. But क्या होगा? You apply vacuum, it will slip. You apply vacuum, it will slip. मतलब vacuum चिपकेगा ही नहीं. Vacuum will always fail when the baby is dead, and therefore absolute difficult MCQ. Yes sir, mother के लिए more risk is forceps, but still I will have to apply a forceps. Is this understood to all of you? Absolutely virgin, very difficult MCQ, and this will crystal clear your this. Sir, can be applied in IUFD cases. Should not be applied. Why it should not be applied? Because it will always fail. मतलब वो फायदा ही नहीं है. Because Chignon formation will not take place in IUFD. Is it crystal clear to all of you? So this covers our entire topic. Don't worry, even if you have not मतलब ये लास्ट वाला पॉइंट याद नहीं भी रखोगे तो चलेगा. But just remember कि IUFD forceps can be applied. Vacuum will always fail. So अगर IUFD है and vaginal delivery we are trying, we would want to try vaginal delivery because vaginal delivery is possible. Vaginal delivery is possible. So no need of LSCS. Okay. We always prefer vaginal. Station +3 तक आ गया है तो forceps लगा देंगे. Why? Because vacuum is safe for mother, but safe for mother, yes, but will fail in IUFD. Vacuum will always fail since the baby is dead. Okay. Next, extremely important topic, 5-star topic, and that is the topic of short pre-eclampsia. Okay. Anybody, what is the difference between gestational hypertension and pre-eclampsia? So beta, again there is no fixed rule, but we try 2-3 times. Okay, 2-3 they say कि you apply vacuum cup, अगर slip हो गया और एक बार लगा सकते हैं, slip हो गया. It depends whether the head is coming down or not. You apply the head and station was supposed +2 and it came down to +3, +4. मतलब it's moving. There is some फायदा हो रहा है. Then you can apply one more time. Otherwise, there's if you then have to abandon and go for LSCS. Forceps generally we apply only once because forceps में generally slip नहीं होता है. So forceps once you apply Either the baby comes out or you do LSCS. Okay. Yes. Now, anybody, what is the difference between gestational hypertension and preeclampsia? Okay. Now, please understand this. This PIH is a outdated terminology. PIH जो है pregnancy induced hypertension, वो word अभी use नहीं करते हैं PIH. Okay. Gestational hypertension and preeclampsia are the words used. Gestational hypertension and preeclampsia are the words used. What is the difference? Anybody? So gestational hypertension में only the blood, हाँ, okay, so कैसे पता? So only when the blood pressure is high for the first time during pregnancy. Okay, during pregnancy. Yes. Yes. So all of you, क्या difference है? हाँ, सीजर no बेटा नवीन एक मिस्टेक हो गया. After 20, no, all of you, BP plus hypertension क्या हो गया बेटा मौजूद? Increase BP and hypertension तो same ही हो गया ना? Okay. See, all this as I told you is pregnancy. Very good, Lipsha. Pregnancy Sultan, very good. Pregnancy induced hypertension ही है. So both these are always after 20 weeks. After 20 weeks ही होगा, because if it is, anybody, what is the word if I use if the BP is high before 20 weeks, or when the patient comes to you in the first visit only 6 weeks, or they tell that doctor, I am now married, my BP is high, I am planning pregnancy. So then we use the word chronic hypertension. समझ में आ गया? If the BP is high before pregnancy, so before 20 weeks, and one more definition I will tell you in some time, then you call it as chronic hypertension. So the difference, my dear student, is that preeclampsia has elevated blood pressure plus very important proteinuria. Is this understood to all of you? Is this understood to all of you? Proteinuria. Okay. So when the only the BP is high, okay, only if the BP is high, I will use gestational hypertension. Is this clear? And yes, if on this high BP, proteinuria, and now the patient gets convulsion, then you call it as eclampsia. Is this crystal clear to all of you? So one thing I need to add one thing. Add one thing क्या मतलब? BP more than 140/90 for the first time after 20 weeks, but no proteinuria. तो खाली बोलेंगे gestational hypertension. इसमें and proteinuria, please behind this number minimum 300 milligrams in 24 hours. Okay. Okay. Minimum 300 milligrams in 24 hours. You need to add. If only the BP is high, and along with that there is now proteinuria, we will call it as preeclampsia. And now if with this there is convulsion, we will now call it as eclampsia. Okay, समझ में आ गया? Yes, can you understood this crystal clear? So now can you tell me, so pre-eclampsia plus convulsion, eclampsia. Okay, after 20 weeks and product. Now, last part. Anybody, can you tell me chronic hypertension, 3 definitions? Chronic hypertension, I want all of you to remember 3 definitions. One definition already you know, okay sir, BP is high at 7 weeks patient came, 8 weeks patient came, BP high. Okay, high BP, high blood pressure before 20 weeks. Very good. Or high blood pressure even before pregnancy. But what is the third definition of chronic hypertension? Can you tell me what will always happen to the blood pressure in gestational hypertension or preeclampsia after delivery? Okay. So as I said, PIH is an old word. We now don't use PIH. What will happen to the blood pressure after delivery? बीपी आफ्टर डिलीवरी, आपने डिलीवरी कर दिया पेशेंट का, तो क्या होगा बीपी? BP will always become normal after delivery. Then only, yes. Correct. So, yeah, okay. So, in gestational hypertension and preeclampsia, the BP always come back to normal. Very good, Neetu. Okay. Will come back to normal after delivery. But in chronic hypertension, the last thing, BP will not become normal after delivery. But when, suppose आज किसी का डिलीवरी किया, can the BP become normal tomorrow? Yes, blood pressure can become normal tomorrow also, but how much time do I wait? Do I wait for 10 days, 15 days, 6 weeks, 12 weeks? So remember, my dear students, 6 weeks was the old criteria. Okay, 6 weeks was the old criteria. The new criteria is 12 weeks. That means, sir, yes, that sir, by the BP will become normal after delivery anytime within 12 weeks time. Within 12 weeks time, anytime the BP will become normal. And therefore, if the BP will not normal even in 12 weeks, then you tell the patient that now you are chronic hypertension. Is this crystal clear to all of you? And before I proceed further in this whole treatment, whether it is preeclampsia or eclampsia or gestational hypertension, this statement I will repeat 5 more times. This statement I will repeat 5 more times. But all of you, please remember this, that I will repeat this statement 5 more times. But remember that delivery is the definitive treatment. Okay, write it down in bold. लैबेटालॉल कब देना है, मैक्सल्फ कब देना है, कब डिलीवर करना है, वो सब हम डिस्कस करेंगे. बट डिलीवरी इज द डेफिनेटिव ट्रीटमेंट. समझ में आ गया? Because as I said, all this is a pregnancy induced condition. So whether it's a pre-eclampsia or eclampsia or gestational hypertension or any complications of this, finally delivery is the definitive treatment. Is this understood to all of you? Okay, so first point number 1, you should be very clear with the definitions. Only the BP is high. There is no proteinuria. I call it gestational hypertension. If the proteinuria is also there, we call it preeclampsia. Convulsion is also there, we call it eclampsia. And this is the 5-star slide, what I told you. Chronic hypertension. Sir, BP is high before pregnancy or even before 20 weeks. That's the second definition. And the last, okay, sir, it was a patient of preeclampsia, hypertension for the first time after 20 weeks. After 20 weeks, matlab a patient of preeclampsia. Correct? Patient of gestational hypertension or preeclampsia. But the BP is even persistent after 12 weeks postpartum. Then you tell the patient, okay, now you have become a chronic hypertensive. Okay, crystal clear. Now, if the BP is normal before pregnancy, why should the blood pressure shoot up during pregnancy? Exact reason is not known, but certain risk factors. क्या है? Yeah, thank you, Mazur. Yes. Okay. Yeah. Okay. So now please pay attention. Ek primary gravidas, because they are exposed to the fetal tissue for the first time. Okay, it is thought that fetal tissue is causing antigenic response in the baby, in the mother. So because fetus is foreign, right? Fetus is half father, half mother. So the father ka part is new, and therefore mother is mounting immune response. So BP बढ़ता है. So young patients, primary gravida patients, twins, because more baby. Okay, twins. And very important, past history. Okay, this is very important. So young patients में होता है generally because exposed to the tissue for the first time, twins, multiple pregnancies, in cases of vesicular mole, all that we'll discuss, pre-existing obesity, hypertension, diabetes, and very, very important past history. If once BP high, again BP can in next pregnancy also go high. I'll tell you. Family history. If your mother, if your real sister BP high, even your pregnancy, you can get BP high. Matlab chance is there, not always, of course, chance, not 100%, but risk is there. Okay, and what is anti-phospholipid antibody syndrome? All that also we'll discuss in the upcoming class. APLA syndrome and thrombophilia. Don't worry, we'll discuss that. And the medicine teacher will teach you APLA syndrome. Again, BP can go high. And the last interesting part, smoking is protective for preeclampsia. That does not mean you tell all your pregnant patients to start smoking. Okay, chalo, start smoking. But some unknown reason, smoking is protective. Okay, but then you don't say the patient to start smoking. Okay, just for the this. Okay. Now, please pay attention. क्या होगा? Yes, very good. Smoking is protective for fibroids, endometriosis, preeclampsia. Now, there is an imbalance between, there is endothelial damage, there is a vasospasm. An imbalance between vasoconstrictors, vasodilators. Vasoconstrictors like thromboxane A2, endothelin 1, all are going to increase angiotensin 2. And prostacyclin nitric oxide, all are going to decrease. Okay, is this understood to all of you? All are going to decrease. Okay, so ये आपको एग्जाम में याद रखना है. And now anybody, what is the theory? ये एक famous theory है जो explain करेंगे. What is the theory of improper trophoblastic invasion? What is the theory of improper trophoblastic invasion? Okay, so now ध्यान से सुनो. Starting में, please pay attention. Starting में, when the placenta is getting formed, for everybody, when the placenta is getting formed, there is high resistance low flow. Common sense, resistance and flow are ulta. If there is high resistance, the blood flow is low. Okay. Now, the trophoblast. Anybody who is invading into whom? Any idea? Tell me one important word in the whole MCQ. If I tell you theory of improper trophoblastic invasion, तो ये क्या invasion हो रहा है? Who is invading? Are the aliens coming to invade? कौन किस में invade कर रहा है? So, the trophoblast from the baby, they will now invade into the maternal which vessels? Anybody in the whole MCQ, in the whole line, only one line is important. Placenta of the mother, correct, but in the placenta of the mother, placenta say, from the placenta, the trophoblast will invade into which vessel? This I told you, these are blood vessels. Correct, this is blood vessel. इसमें high resistance है, low flow है, and this trophoblast, they will invade. बेटा, very good. Lining of heart. लिप्शा, एक ही word. Very good, Sultan. एक ही word याद रखना है. Spiral vessels. Spiral vessels are nothing but your branch of the uterine artery. तो ये अगर ट्रोफोब्लास्ट वेसल के अंदर घुस जाएंगे और वेसल का इलास्टिसिटी को तोड़ देते हैं, they will damage the tunica media, and that is beneficial. This should happen. And what will happen after this? पूरा उल्टा हो जाएगा. उल्टा हो जाएगा मतलब के this high resistance will now become low resistance, and low flow will now become high flow. This is normal. This is normal. This should happen. So the baby will get very good blood supply. Baby will be getting more and more blood supply. This is the theory. कि यहाँ पे this happens in waves. Okay, first wave happens at around 8-10 weeks, and second wave happens at around 16 weeks. Okay, so around 16-18 weeks the trophoblast invade, and if this does not happen, ये नहीं हुआ, this should happen, this is normal, ये हो गया तो normal, very good. But if this does not happen, then the vessels will remain in a state of spasm only. तो क्या होगा? BP बढ़ेगा, and again anybody baby को low flow, तो क्या one more complication? Everybody logic, if the baby is low flow क्या होगा? तो baby will also develop IUGR. Okay, is this understood to all of you? Okay, there is complication of IUGR also. So same theory, yes, same theory is for IUGR as well as preeclampsia, and therefore indirectly whenever the mother is having preeclampsia, baby is likely to develop IUGR. So the important part is, yes, very good. Okay, sir, normally in normal conditions, the spiral vessels invaded by trophoblast. In preeclampsia or IUGR, there is a incomplete trophoblastic invasion. ये generally 18-16-18 weeks पे होता है, नहीं होगा करके 20 weeks के बाद BP बढ़ने का start हो सकता है. Is this understood to all of you? Okay, so just keep this in mind. Okay. Very good. Now, before I proceed further, can anybody tell me what are the complications of this condition? Preeclampsia, eclampsia complication. Chalo, 3-4 you already know. What are overall? Randomly just start telling me. Kya, this whole topic, preeclampsia, eclampsia, what are the complications? क्या हो सकता है? BP very high. So eclampsia, yes, pre-eclampsia complication, eclampsia. What else? Think. IUGR, very good. मदर एंड बेबी सेपरेटली, तो क्या होगा, मदर को विल डिस्कस, ओके, वेरी इंपॉर्टेंट, abruption, hypertension से abruption after delivery, PPH, I already told to you. And also do not forget HELP syndrome. What is all this we'll discuss. And baby ko IUGR, oligohydramnios, yes, organ damage, liver damage, very good. Okay, and your baby ko IUFD also, and mother can also have complication, renal failure, and mother can also die. Okay, so we will discuss this in some time, but basically kya hoga, you don't have to remember all this, but I'll just show you this slide. What is the very, very important, very good 5-star slide? Okay, sir, mother ko eclampsia, abruption, HELP syndrome, DIC, renal failure, and kal bataya PPH. And baby ko IUGR, even IUFD, early delivery will be required, and therefore even प्रीमेच्योरिटी ओलिगोहाइड्रामनस. मदर का मेन 3 याद रखेंगे खाली, एक्लाम्शिया, abruption is a very important risk, what is HELP syndrome, and DIC I will explain to you, and then of course your end organ failure like this ARDS and renal failure and PPH. Okay, so these are the main dangers for the mother, and of course even mother can die, and baby ke liye mainly the risk is IUGR, baby can also die, and prematurity also. Okay, is this understood to all of you? Okay, now this we are not supposed to remember at all, you are not supposed to remember, but it's the same thing what I told you. Okay, there is matlab what will happen, there is vasospasm, so BP will shoot up, abruption, oliguria, liver damage, convulsion, capillary leak hoga, there's proteinuria, baby will, mother will edema, feet hemoconcentration, thrombocytopenia. So this we are not, this is only for final year theory student to write theory answer, but now please pay attention. Okay, all of you. Now if the BP, so ye aapka basically etiology ho gaya, you know the complications. Okay, this I'm coming to that in a minute. Now anybody, what are the any if the mother ka BP is high, for this condition what is considered alpha methyl dopa ACE inhibitors. What is the drug of choice for this condition? Anybody? What is the drug of choice for this condition? Yes. So alpha methyl dopa many years back was the drug of choice. And can anybody tell me out of this which is absolutely contraindicated? Which is absolutely contraindicated? Which is absolutely contraindicated? Anybody? Very good. Okay, please. No, Lipsha. Yes, ha. Okay, very good. ACE inhibitors are absolutely contraindicated in pregnancy. What can happen? So they will act on the fetal kidney problem, and there is the medicine teach. Apna pharmac teacher will also teach you fetal kidney and fetal renal artery will have a problem, and there is problem with fetal kidney. Yeah, malformation ज़्यादा मतलब mainly kidney का problem and IUGR and oligohydramnios. There's risk of oligo, IUGR and even IUFD and all that. Okay, so ACE inhibitors are absolutely contraindicated in pregnancy. Alpha methyl dopa was many years back. Today labetalol is the first drug of choice. Okay, and labetalol may be remember कि when it is only hypertension we give oral labetalol. But if it is very severe, like if it is hypertensive crisis, anybody, hypertensive crisis matlab ke BP is 180 120, then you give IV labetalol. Okay, so whether the question is about hypertension, okay, drug of choice for hypertension in pregnancy, if this is the MCQ, or your preeclampsia, then please mark labetalol only. If it's hypertensive crisis, nifedipine is also allowed, but second. Okay, and the last one, okay, remember, so only 4 drugs are allowed. Okay, what are the 4 drugs allowed in pregnancy? 4 drugs which are allowed are labetalol is allowed. Labetalol is the first. Nifedipine can also be tried. Alpha methyl dopa was available. And lastly, in hypertensive crisis also we can give hydralazine also can be used. Okay, in hypertensive crisis when the BP is very high. Okay, but otherwise IV labetalol. Okay, yes, sodium nitroprusside also can be given very severe cases. Okay, very severe cases, sodium nitroprusside may be given, or NTG, nitroglycerin, you may give. Okay, but mainly remember IV labetalol. Okay, IV labetalol, sodium nitroprusside also you avoid, but mainly IV labetalol is what you give. And if required, even hydralazine can be given. Okay, in hypertension also, and hypertensive crisis also. Okay, now all of you. So basically पहले मीनिंग पता चल गया, डेफिनेशंस पता चल गया, ड्रग ऑफ चॉइस पता चल गया, एंड आपको मेन स्लाइड ये कॉम्प्लिकेशंस परफेक्टली बाय हार्ट हो गया. नाउ वेरी इंपॉर्टेंट, what are the 5 dangerous signs and symptoms if a patient, and why do I call it dangerous? Because sir, if the patient develops these dangerous signs and symptoms, the whole management will change. What are those? These 5 you should know by heart. And what do they indicate? The 5 dangerous symptoms, anybody at least name 1 or 2? At least you can name 1 or 2. What are the 5 dangerous signs and symptoms which tell you कि ये तो गड़बड़ है? Yeah, we are having a break, beta. Vijay, 5 minutes. We are going on a break. Okay. Yes, these 5 dangerous symptoms, they are called as premonitory symptoms. You should know by heart. नहीं बेटा, seizure के पहले. Okay, please by heart this 5-star slide. 2 minutes we are going on a break. This is the 7-star slide. If anybody आपको wakes you up from the sleep, then also you should know this by heart. Okay, headache, oliguria, epigastric pain, nausea, vomiting, blurring of vision. Okay, headache, oliguria, epigastric pain, nausea, vomiting, blurring of vision. And why these are called as dangerous? Because they indicate impending eclampsia. Are you understanding? Yes, it's a spectrum, sir. Okay, the patient is moving towards convulsion. Okay, Masood, अभी तक कन्वर्जन आया नहीं है. सुल्तान सेल्फ सिंड्रोम विल डेवलप लेटर एज अ कॉम्प्लिकेशन. ओके, सो आई एम जस्ट टेलिंग यू कि शी वाज ओनली प्री एक्लाम्शिया, नाउ शी बिकम्स impending eclampsia. Okay, if I don't act immediately, she will then get convulsion anytime. She will get eclampsia. So from pre-eclampsia, if any of this five, generally 2-3 develop, the presence of this five dangerous signs and symptoms in a patient of pre-eclampsia indicates that now she is impending eclampsia. Is this understood to all of you? Please repeat after me. Headache, oliguria, epigastric pain, nausea, vomiting, blurring of vision. Okay, headache, oliguria, epigastric pain, nausea, vomiting, blurring of vision. They are so dangerous that these are the dangerous symptoms. They indicate impending eclampsia in a patient of pre-eclampsia. Okay, is this crystal clear to all of you? What will you do when these symptoms develop and how to take the management? All that we will discuss after the break. But please by heart this, okay? Is it clear? Headache, oliguria, epigastric and nausea. It just tells you that the condition is worsening. Okay, sir, the patient was only pre-eclampsia, but now she is now impending eclampsia. It's like a severe pre-eclampsia. Okay, it is basically impending eclampsia. Okay, so when high blood pressure is only given in the question paper, management is different. When these dangerous signs and symptoms are told to you, headache, right after me, last time, headache, oliguria, epigastric pain, nausea, vomiting, blurring of vision. Okay, these are telling you, okay, this is very dangerous. Any 2-3 may also be present. It's not at all 5. Patient can just have epigastric pain, nausea, vomiting, blurring of, they'll give you in the question paper. Okay, so it is 11:25, 10 to 15, 10 to 13, 14 minutes break. When we come back, very important, all Maxel, magnesium sulfate, don't be late, very important. We'll give you a break for some time and we proceed further after that to the topic of this. There's still a lot of things remaining in this topic. We'll discuss after the break. Okay, clear? So it's a break now for all of you. Hello, hello, hello. So all students come back. Quickly settle down. We are starting now in 2 minutes. Is the audio video all clear? Okay. So very important discussion now. I want nobody to miss this part. Please pay careful attention and please have a lot of focus. And it's going to be very interesting also. Okay. Yes, that when I have a patient who is, the etiology, the clinical fee, the drug of choice, medicines, which to give, now coming to very important and the complication and this impending eclampsia. Now, okay. And what are those impending eclampsia signs and symptoms? Headache, oliguria, epigastric pain, blurring of vision. They are called as premonitory symptom. They indicate that condition worsen हो रहा है. Patient को कभी भी convulsion आ सकता है. Now, can you tell me, suppose if I have a patient of impending eclampsia, correct? But we are only 24 weeks, 26 weeks pregnant. We matlab the patient. Now all of us today know, see that complete lung maturity 37 weeks. But suppose the delivery has to happen early, 34 weeks baby, 32 weeks baby, 34, 35, depends on your NICU capacity. But a 34 weeks baby today, most of the places with a good NICU can survive. Even 32 weeks baby can survive. Sometimes even 30 weeks and 28 weeks baby can also survive. But suppose the patient is only 22 weeks, 24 weeks, 26 weeks, 28 weeks. What do I do? Because the patient is having now impending eclampsia. Okay. Is this understood to all of you? Is this understood to all of you? So what do you do? Okay. So point number 1 ध्यान से सुनेंगे सब लोग. आपने हिंदी पिक्चर में फेमस डायलॉग सुना होगा. A doctor comes out of the labor ward and says the iconic dialogue, हम माँ और बच्चे में से किसी एक को बचा सकते हैं. Have you heard this dialogue before? I mean, the doctor says, either I can save the mother or I can save the baby. You tell me whom to save. Then what will happen? The loving husband will say, yes, yes, sir, please forget about the baby. Save my wife. The Khadu's mother-in-law will say, doctor, forget about the bahu ko marne do, lekin at least bachche ko bacha lo. So whom to save? Okay, save the mother, save the baby. Indian government save the tiger, save the cheetah. Doctors are saying first save the doctor. To whom to save? Anybody? Save the mother, save the baby, save the tiger, save the doctor. Whom to save? Save the intern. Whom to save? Okay, is it clear? So please understand that this kind of option is never ever given to the relatives. It is always mother first, because अगर mother है पीछे पूरा cricket team आ सकता है. That means, sir, whenever there is impending eclampsia, that is the last day of the pregnancy. So sorry, the pregnancy cannot continue further and we will have to go and do the delivery. Let the baby be 24 weeks, 26 weeks, 28 weeks, or for that matter 34 weeks or 36 weeks. Are you understanding this? Okay, because between mother and baby, mother is more important. Buffering? Okay, I have no okay, let me just refresh. I'll just repeat all this point. Okay, because actually the same thing, I'm at the same place and the same internet, no problem. Let me just refresh once and all of you tell me if it's better or not. Okay. Hello, 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 hello. Yeah. Now is it better? Now हाँ वीडियो भी होगा बट अभी लोड होगा because I am at the same place and I am at the same location just before the break. We were there, same hai, and my internet signal is also completely full. Yes. Okay. So I'm back now. I think just check now. I think it should hopefully it should be okay now, and tell me if it's all okay. Hello, hello, hello. Can all of you hear me? Can all of you see me? Am I visible to all? Am I audible to all? Is it better now? All okay now, student? Can you please hear me? Can all of you hear me? Can all of you see me? But I really don't know what is to be done because I am at the same place what we were, same internet, my other things are working perfectly fine. Yeah, okay now I think it should become better now. Just all of you quickly can from your end, can you refresh the page? Can you just quickly refresh the page? No, no, we can't end today's class. I would want to at least teach. We can try to leave you slightly early, but we can't end today's class. Okay. Yeah. Because from my end there is no lag at all. It's absolutely perfectly fine. I can also check the internet speed. But I will not know new link if it is okay. Should I end this class and then should I again start the new class? Okay, okay, that's the only option. We will have to. Okay, now can all of you check, please? Now can anybody check and let me know how things are? Can all of you check now? Is it all okay? Getting more than 50 MB. Just let me know. Otherwise, I will have to end this session and start a new session. Is the website problem? Okay, okay. Okay, chalo. Let us do one thing. Let us do one thing. I will end this session and all of you join back in 2 minutes with a new link. Okay. I will end this session over here. We have kept this label as day 3. Yeah, yeah. Okay, okay. Chalo.